Thank you for that introduction, and I'm excited to speak with you today. These are my disclosures. And so just to orient you to what I'm going to be talking about for the next few minutes, I was reflecting on, it was 3 years ago, 2017, when I first spoke about the development of our new program, Golden Compass, at Ward 86. And I'm just going to briefly talk about an overview and the development of the program, but then spend time talking about our initial evaluation using an implementation science framework, RE-AIM, and then talk about what we're doing currently, planning for the future, and how we've adapted the last several months during the COVID-19 pandemic. So the Golden Compass program came out of several things, but the most important being our process of stakeholder engagement, where we did surveys and focus groups with patients and providers at the clinic. And in fact, that's where the name of the program, Golden Compass, came from, this idea of navigation and the complexity of navigating the healthcare system, and that the term golden years was the acceptable term for aging across all of the focus groups we did. And then drawing on this idea of a compass and navigation, we used what resources we had locally to then focus services around points of the compass. They don't all exactly align, but as an overview, heart and mind, we're lucky to have Dr. Priscilla Hsu, an HIV cardiologist who now comes once a month to the clinic for her own cardiology clinic, done brain health classes, cognitive assessments in geriatrics clinic. In the Eastern Point, focusing on bones and strength, fall assessments, functional assessments, and a weekly chair exercise class. The Western Point, connecting people to make sure they have age-appropriate screenings and helping them connect to services. And then the Southern Point, network and navigation, addressing social isolation and loneliness, and really working to strengthen our partnerships with community organizations. So sometimes it's also helpful to hear a story of how a person might go through our program. So this is one example. This is a 62-year-old who identifies as a Latino male. He also identifies as an HIV long-term survivor. And when I saw him in clinic, one of the things that stood out was he was reporting dizziness. We noticed his blood pressure medications had just been changed, and he was also on medicines for an enlarged prostate. And we checked his blood pressure, and it dramatically dropped from laying to standing. So we adjusted his medications and his dizziness improved. At the time, he was also feeling more isolated because he had lost a family member. So in addition to connecting him to a therapist, we connected him with one of our community partners who paired him with a volunteer who was still meeting weekly with him 2 years up until the COVID-19 pandemic. And then he really became highly engaged in all of the classes we were offering. And you can see when he was reflecting on his mental and physical health, you can see what he said about the program in the quote on this slide. So that's an overview of some of the services and how someone might interact with the program. So I'm going to present findings that were just published this year on the first year and a half, which involve both quantitative and qualitative methods using the RE-AIM implementation science framework to guide our evaluation, which stands for reach, effectiveness, adoption, implementation, and maintenance. Because this was only the first year and a half, we didn't examine the maintenance phase. But in terms of reach, which was at the patient level, we saw just over 200 participants who participated in one or more aspects of the program. And in interviews, it was interesting to hear from providers that they still sometimes had difficulty making a direct referral to see me, a geriatrician, with some of their patients, especially those in their 50s. And then in terms of effectiveness, we focused on early outcomes like satisfaction and acceptability of services. And we found that more than 90% of the patients and providers surveys were very satisfied with services. And in interviews, medication assessment, mobility, and cognitive evaluations were all viewed as very valuable. At the adoption, this was at the provider level. So more than 85% of providers referred at least one patient to the geriatrics clinic, and 60% of providers had referred at least one patient to the cardiology clinic. And then implementation is actually how faithful were you to what you set out to do. And if you think of that figure I showed earlier, we actually did predominantly what we set out to do. And in interviews, one of the themes that was notable was that the co-location of services was an important feature of the program. So what did we learn in this initial evaluation? I think the one thing that really stands out to me that was, despite all our best intention to have a program name without HIV, without geriatrics, still addressing the stigma of ageism, because it was hard for providers to sometimes refer to see me without using aging or geriatrics. And I think also recognizing that there are stigmas with some of the assessments, like cognitive assessment, that are done in clinic. And one of the suggestions was framing as helping you to stay healthy as you're living longer with HIV that we're now using. For those who are potentially considering starting a program or a clinic, I think the other thing is it just takes time to develop and implement. For example, our classes initially started out with only 2 or 3 participants, and it took time for them to reach the full class size. And then in terms of outcome evaluation, we focused on early outcomes that I presented, and you'll hear here at this conference from Vivian Chen, who will present on some of our prescribing and polypharmacy work. I think what I've learned is that qualitative methods can be really important, especially for consultative models. I think as a field, we need to think through what are the outcomes. Is it quality of life? And just thinking through, sometimes if you're a consultative clinic, it can be hard to show a change in a quantitative survey of quality of life. And then just things we can talk about in discussion, challenges for the field, who would benefit from consultation, the role of the consultant, and ongoing funding. And then looking forward, so what did we learn? So we're working on expanding the reach of the program. I can share we've seen another approximately 200 additional people. And to expand the reach for those who had trouble coming in, especially having an e-consult option so that providers can still ask a question even if the patient doesn't come in for the appointment. Our nurses, all of the nurses in the clinic, were getting ready to expand screenings, and we're being trained on how to do a lot of the geriatric assessments. And then we are also working on expanding just general geriatrics and aging knowledge of providers and patients, both. And we are doing this in partnership with our Optimizing Aging Collaborative, which is our geriatric workforce enhancement program that does training of providers and staff. And then, of course, this year we've all had to adapt how we deliver services. And when COVID-19 started in March, like most clinics, we switched to telehealth visits, especially for specialty services initially, and then slowly have been increasing in-person capabilities. And just to point out that I do feel that many of the geriatric assessments can be done, especially on a video platform, and even can be adapted to phone, although sometimes I find that more challenging. Our classes also moved to a virtual platform. And then our clinic was very proactive initially in doing outreach calls to older adults. And as shelter in place continued locally, we then began doing additional outreach calls to some of our older patients to address things like caregiving concerns and other issues that might be coming up as the pandemic continued. And I think one of the things that this brought up was the issue of the digital divide. So some of our patients, as we moved things to virtual platform for classes, were not able to navigate connecting either through lack of internet or lack of a device. And the one thing I will say though is I think also thinking through how telehealth can improve access in some cases. We actually just did a focus group with some of our participants, and for some, especially those who had to travel or for mobility limitations, they actually want the virtual platform to continue even when in-person classes resume, because it made it much easier for them. And so if we had to take a really big picture view, for those who are developing programs or clinics, the stakeholder engagement and knowing your local resources are the critical things in developing a program. For everyone, whether you're developing or evaluating programs, I think implementation science frameworks can really help guide that process. And then finally, as we're all adapting right now, I think it is important that telehealth can actually improve access and have an important role as long as we can bridge that digital divide. And I just want to thank everyone that has worked on this project, and thank you for your time today.